Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article number 38. Welcome to the Pain is Not the Only Problem podcast. Article 38. Pain is not the only problem. Game day plan. These articles intend to reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms, meet patient expectations and satisfaction and clinically meaningful results, recommend a conservative non-surgical course of care to override pain instantly, and restore ADLs and patient confidence on the first visit at low cost. The game day approach evolved from the performance-based determination of athletes to get results in a competitive platform. It also evolved from my inspiration to create an alternative platform for the current healthcare system that does not provide an efficient nor effective conservative treatment plan for clinically common low back pain. If winning at the game of satisfactory low back pain outcomes is the play clinicians are running, patients will never become champions. The rules have to change. Clinically meaningful results implies a treatment plan that provides biomechanically improved outcomes and patient satisfaction reflected through patient values and patient expectations. Clinically meaningful is similar to strategically meaningful. Team coaches do not get superior performance from the team unless there is a game plan and the entire team understands, supports, and implements that plan. Team coaches use plays that work and discard plays that do not work, since points are in jeopardy. When clinicians use low back pain plays that do not work, patients are being pointed in the wrong direction and can't win. It is useless to provide a surgical intervention on a disc herniation simply because it is seen on an MRI if there is no surgeon's promise of full recovery and return to premium performance. Removal of the observed herniation is not the expectation of the athlete. Hastened RTP or return to play is the expectation to be achieved. Surgery will always delay RTP and is never at low cost. Common low back pain medical approaches are intended to manage observed anatomical contributors without ever considering faulty motor patterns, spinal stability, performance deficiencies, accuracies in motor commands, active range of motion, nor sports specificity, including ADLs. Conservative care is intended to manage low back pain firstly by treating the symptoms of the extremities, then by centralization. 1. Identifying the faulty motor pattern. 2. Reducing and eliminating limb radiation. Then 3. Reducing extremity sensitization. And then 4. Producing negative extremity orthopedic exams. Then 5. Finding palliative extremity positions. Then 6. Improving joint play and stiffness. Then 7. Restoring limb function, integration to the whole body system. This extensive list competes with surgery. This extensive list can be performed in the first encounter visit at low cost. Next, conservative care is intended to manage low back pain by 1. Identifying the non-extremity causes and symptoms. 2. Reducing the number of spinal levels involved. Then 3. Reducing spinal symptoms. Then 4. Producing negative pathological reflexes. Then 5. Finding a palliative low back pain position. Then 6. Improving joint play and stiffness. And then 7. Restoring spinal function. This extensive list can be performed in the same first encounter visit at low cost. Game day is about clinical conservatism. There are 9 conservative approaches. Number 1. Primum non nocere. Never do harm. This means 0 side effects, no risk to the patient, and a 100% provider promise. 2. Minimum intervention. Provide comprehensive patient education and accountability on the first visit. 3. Reduce patient risk. Have the patient do a self-evaluation to change lifestyle choices and behaviors in order to get results. 4. Least side effects. In the medical model, currently there are 668 deaths per day due to medical error. Conservative deaths per day is 0. 5. Patient explains self-identified contributors from their problem list and explains any setbacks. These become therapy pointers. 6. Least invasive interventions to minimize scarring, risks, impediments, and death. 7. Individualized care to address a patient or athlete's specific case management. 8. Patient accountability to comply and participate as the primary giver themselves. 9. Lowest possible cost, treating in the least amount of time. Game day is about patient-athlete performance excellence. There are 9 excellence approaches. 1. Do no harm to your teammates or to team values. 2. Discover winning plays early. 3. Reduce negativity and distraction. Embody a victorious lifestyle. 4. Least lost time due to injury and setbacks. 5. Teammates support each other. Coaches provide training and wisdom. 6. Train for the best performance with least risk to team values. 7. Teammates recognize individual athlete values to be exploited for team gains. 8. Athletes owe their value to the team. 9. Least setbacks, least injury, most gains. If we take a look back at the game day being about clinical conservatism and game day being about patient-athletes' performance excellence, you'll notice that the 9 contributors to conservatism line up with the 9 contributors to performance excellence. In a sense, we are taking, for example, number 1, primum non nocere, never do harm, and we are correlating that with game day. Number 1, do no harm to your teammates or to team values. If we look at 2, minimum intervention, we can go to game day plan and say discover winning plays early. If we go to number 3, conservatism, reduce patient risk. Game day, number 3, reduce negativity and distraction, embody a victorious lifestyle. Number 4, conservatism, least side effects. Number 4, game day, least lost time due to injury and setbacks. Conservatism, number 5, patient explains self-identified contributors. Number 5, game day, teammates support each other, coaches provide training and wisdom. Number 6, conservatism, least invasive interventions to minimize scarring, risks, impediments, and death. Number 6, game day, train for best performance with least risk to team values. Number 7, conservatism, individualized care to address a patient-athlete specific case management. Number 7, game day, teammates recognize individual athlete values to be exploited for team gains. Conservatism, number 8, patient accountability to comply and participate as the primary caregiver. Number 8, game day, athletes owe their value to the team. And then finally, conservatism, number 9, lowest possible cost, treating in the least amount of time. Number 9, game day, least setbacks, least injury, most gains. One standard of care for low back pain assumes that the symptom generator is not assumed to be IVF nerve impingement, disc herniation, piriformis syndrome, SIJ syndrome, or canal stenosis simply because it can be seen or discovered on advanced imaging. There must be progressive neural deficits of 911 nature and efferent deficits. Conservative care begins with evaluation, numbness, tingling, electric pain in the lower extremity, bowel and bladder changes, determine dullness versus localized pain. Determine distal versus local pain. Determine tenderness location. Palpate everything on both of the lower extremities. Determine afferent deficiencies, both lower extremities. Determine active and passive range of motion with and without pain of both the lower extremities. This extensive list competes with surgery and can be performed in the first encounter visit at low cost. Then assess pointers to ADL changes. How has the patient chosen to modify ADLs? What are the provocative positions? What are the palliative positions? What are the pointers to inflammatory contributions? Diet, autoimmune, acquired, exacerbation, non-healing. Then what are the pointers to the sympathetic lifestyle? Haste, emergency, distraction, productivity. And then what are the pointers? Then what are the pointers to the patient's sympathetic lifestyle? So this includes... Then what are the pointers to the sympathetic lifestyle of the patient? This may include haste, emergency lifestyle, distraction, overproductivity. And then what are the pointers to the phasic healing, overlapping phases of unresolved tissue repair? Then provide parasympathetic lifestyle changes and inflammatory diet. The first encounter evaluation can be completed in less than 20 minutes. Does your course of care provide functional confidence and systemic adaptability and patient satisfaction? Or does it just get you paid? Since pain is not the only problem, and since medicine is never business as usual. Thank you for joining me today. Let's advocate for improved patient satisfaction and the profession. Let's demonstrate a cross-culture willingness to strengthen medicine.